Good day, everybody, and thank you so much for your presence to this very exciting webinar today. And I am Dr. Ida Ismail Pratt, and welcome to the IPVS International Papillomavirus Society in collaboration with the Asia Pacific region HPV Coalition collaboration, the webinar Cervical Cancer Vaccination and Screening in the Asia Pacific during the pandemic. Where do we go from here? Now, 17th of November 2020 is a historic date, and as all of us are aware that it is the day when WHO actually announced the cervical cancer screening elimination strategy towards 2030. And certainly at the same time, and this is during the COVID pandemic, and because of the COVID pandemic and the restrictive measures as well, we know that cervical cancer screening is one of the cancer screening services that has actually been severely affected due to the COVID pandemic. And this is especially in the Asia Pacific region as well. So the aim of the webinar today is that we would like to actually increase the awareness of the challenges of cervical cancer screening in the Asia Pacific during this pandemic, and also is an amalgamation and exchange of ideas with expert panels from all over the world, especially in the Asia Pacific, on how we can actually overcome these challenges during these very trying times. So I would like to first introduce myself. I am Dr. Ida Ismail Pratt. I am here in Singapore. I am an OBGYN specialist here in Singapore. I also wear a few hats. I am the one of the education committee for the International Papillomavirus Society, IPVS, and I also act as the secretary for the Asia Pacific HPV Coalition webinar. The HPV Coalition. In Singapore, I am also the vice president for the Society of Colposcopy and Cervical Pathology of Singapore. So without further ado, that's me. I'm doing this webinar now, and I will be moderating this webinar with my colleague all the way from Australia. Hi, Jeannie. And I'll give you Jeannie just to introduce herself as well.
Hey everybody, and thank you for giving up a Saturday. As Ida said, I am Dr. Ginny Mansberg. I'm a family medicine physician in Australia. That means that I feel a little bit intimidated with my fellow HPV Coalition APAC members and the esteemed panel we have today, but I'm often at the coalface actually diagnosing HPV related illnesses, and my passion for this area led me to become a medical advisor to the Australian Cervical Cancer Foundation. And so without further ado, don't forget we've got a great panel coming up. Amazing experts that have been gathered from around the APAC area, and what I'd like to see is that everybody putting in your questions, putting in your comments. This is not meant to be us talking at you. We really want to be able to answer all of your questions, so use the chat format, use the Q&A box, because you won't get such a collection of amazing experts too often. Back to you, Ida.
Thanks, Jeannie. And right, so the first thing is that what I would like to do is just to give a short summary what actually IPVS and Asia Pacific HPV Coalition is for those who are not familiar with us. So the IPVS is actually a global authority on papillomavirus. Then the mission of the IPVS is to contribute in terms of research, especially translational research into the new clinical application and public health policies. IPVS also promote and support education about papillomavirus and also help in career development for all those who are interested in papillomavirus related research. And the society has members from more than 50 countries, and expertise are from epidemiologists, geneticists, virologists, and as you can see on various areas. This is the IPVS officer, and with our president, Professor Margaret Stanley. And this is also the IPVS board members as well. In terms of the Asia Pacific HPV Coalition, Basically, these are the founding members comprises of thought leaders and with deep expertise in the public health policy and advocacy and evidence-based research in tackling HPV-related issues, in particular in the Asia-Pacific region. The coalition is actually co-chaired by Professor Suzanne Garland and also Dr. Suresh Kumarasamy, and you can see all the founding members. And we are not just all healthcare workers, because we do believe that cervical cancer is not just a woman's problem or a healthcare problem. It's actually everybody's problem. Therefore, the founding members of the coalition includes all variety of healthcare workers and advocates for cervical cancer screening as well. And we tackle issues pertaining especially to awareness and prevention, screening and treatment, including HPV-related diseases, regardless of gender. Okay, so I'm going to stop sharing, and what I'm going to do is I am going now to introduce our first panelist, Dr. Suresh Kumarasamy. And Dr. Suresh is a gynecologist. He is also a gyne-oncologist in Malaysia, in Penang actually, and he is also the president of the Obstetrics and Gynecological Society of Malaysia, and is also a council member of the Asian Society of Gynecology Oncology, as well as being an inaugural co-chair for the Asia Pacific HPV Coalition. So with that, Dr. Suresh, I will give the audience to you. Thank you very much.
Thank you, Ida. These are my disclosures. 3 things affect cervical cancer prevention. They are education, gender equity, and poverty. Since the onset of the COVID-19 pandemic, what is very clear is it has increased the number of people who are in poverty. This slide comes from the World Bank, and it shows the number of people in millions who are in extreme poverty, where extreme poverty is measured as the number of people living on less than US $1.90 per day. And you can see in the year 2020, about 88 million people in the world have gone into extreme poverty. Whereas in the prior 25 years before that, other than the time of the Asian currency crisis, the numbers have been decreasing year by year. In our part of the world, the rate of extreme poverty is seen in this screen. And you can see over the years, the number of people have been decreasing, but in the year 2020 and year 2021, the projected rates of extreme poverty have increased. This is a study done in the Asia Pacific. It is a survey of 167 labs in 24 countries. And the purpose of this survey was to look at the impact of COVID-19 pandemic on cytology practice. The countries and labs where these, which were surveyed, are shown in the map in the inverted triangles in red. Basically, 20 structured questions were asked, and they covered 4 areas. Were there restrictive measures limiting patients' access to healthcare? Was there a need for personal protective equipment or special facilities for biosafety? Were there modifications of cytology workflow and rearrangement of workforce? And were there changes in case loads and malignancy? And the results are seen in these pie charts. The red indicates where the issue that was asked, or the question that was asked, remained unchanged. So if you look at introduction of new biosafety protocols, the light blue shows that 54% of labs had to implemented new biosafety protocols. In new work arrangements, again, 41.9% of people working the labs started to work in shifts, and 9.4% worked from home. And looking at redeployment of cytology teams to work in other areas, 28.5% were part-time deployed to other areas, and 9.6% were deployed full-time to other areas. In the lab surveyed, about 34% said they were not equipped to meet standards of biosafety, and 54.5% introduced new tissue processing protocols. This study also showed that 80% had a significant decreased case workload, and 43% had a decrease of more than 50% less gynae specimens, and 75% had a decrease of more than 10% in cervical vaginal smears. The rates of malignancy detection from cervical smears was unchanged at 68%. This other study was carried recently by the Asia-Pacific HPV Coalition. 25 people were surveyed in 17 countries. Of the 17 countries surveyed, 12 countries responded to the survey, and these countries are seen in the right side of this slide. So the background of cervical screening in these countries was inquired, and the left side of the slide shows the different types of cervical screening programs that were existing in these countries. So we move from left to right. There was cytology only, VIA only, VIA and cytology, HPV primary screening with cytology triage, primary screening using both cytology and HPV DNA test, and lastly, cytology, VIA, and or HPV DNA test. So a large variety of different methods of cervical screening. And when the impact of the COVID-19 pandemic was studied, in 56% of the countries, there was a significant impact. In 36%, there was some impact. And in 2 countries which had no impact, they were South Korea and Taiwan, which corresponded to 8%. Another question that was asked was, in what way has COVID-19 impacted cervical cancer screening in your country? Again, moving from left to right, suspension of cervical screening service. The second bar says closure of outreach clinics offering cervical screening services. Next is deployment of staff from cervical screening services to COVID-19 services. Next, reduce hours for cervical screening and services. Small number had closure of colposcopy clinics. Next is reduce hours of colposcopy clinics. Next is postponement of colposcopy appointments for pre-invasive cervical disease, and small numbers of reduced number of patients in colposcopy clinic. No impact, only emergency cases seen, and not sure. Moving on to HPV vaccination, within the countries surveyed, there were a number of different types of HPV vaccination programs in place. School-based national HPV programs were in Australia, Malaysia, Singapore, Hong Kong, and Thailand. Non-school-based HPV programs were in Japan, South Korea, and Philippines. And in India, Indonesia, and Bangladesh, the vaccine was available, but there were no national immunization programs. Again, when the respondents were asked about the impact of COVID-19 on HPV vaccination, 52% said there was significant impact, 28% said there was some impact, and Singapore, South Korea, and Taiwan, which accounted for 20% of the responses, said there was no impact. When they were asked in what way has COVID-19 impacted HPV vaccination programs in your country, again moving from left to right, the school-based HPV vaccination program in my country has been suspended. That's extreme left. Then a similar number of people said that the school-based HPV vaccination program in my country has been postponed to 3 months or less. Slightly more said that the school-based HPV program in my country has been postponed indefinitely. Small proportion said HPV vaccination is not available in my country. There are no changes in the HPV vaccination program or service in my country. And the last 3 bars are the HPV vaccination service in my country has been suspended. The HPV vaccination service in my country has been postponed to 3 months or less. And lastly, the HPV vaccination service in my country has been postponed indefinitely. When they were asked if there were additional initiatives to overcome challenges due to the COVID-19 pandemic, India said that there was an advocacy program by the Indian Cancer Society, and there was also an online program targeted to middle and high schools, as well as women's health groups. Bangladesh said they had completed preparations for introduction of a school-based program during the COVID-19 pandemic. In the Philippines, there was a move to HPV vaccination to a community-based program because of a surge of COVID-19 cases in the capital. Indonesia introduced some webinars, and Australia introduced education material to the general public. In total, 41% of countries introduced additional initiatives. In concluding, I'd like to quote from this paper by Feldman, who brought out the subject of COVID-19 and said that we should rethink cervical cancer prevention. Among the issues discussed were self-sampling for HPV allows patients to be tested at their own convenience, implementation of new risk-based algorithms for management of abnormal results, provide evaluation and treatment in a more efficient way, automate reminders and improve education virtually, provide culturally and linguistically appropriate education, and combine HPV vaccination of eligible people with other useful new vaccines. There's another paper which was published early this year in which Professor Suzanne Garland is one of the authors. And these were 4 pillars which were recommendations for HPV vaccination after the COVID-19. These were increased global financial investment in HPV vaccination, improved vaccine supply, and accelerated use of single-dose schedule, education and social marketing, and universal-based, school-based delivery. Thank you very much for your attention.
So thank you, Suresh, and certainly thank you so much for that presentation. It just gives us a background of what the effect of a COVID pandemic has in our region in the Asia Pacific. And as you can see, the effect is actually quite major at the moment. So the question beckons, where do we go from here? And with that, I would like to introduce the rest of the panelists. And when we are going to the main session of this webinar. The first panelist I would like to introduce is Professor Suzanne Garland, and she doesn't really need a lot of introduction. Professor Suzanne Garland is an internationally recognized clinical microbiologist and sexual health physician, and she has led research into HPV with phase 3 clinical trial for HPV prophylactic vaccines and more, vaccine effectiveness studies as well, and she is the inaugural co-chair of the Asia Pacific HPV Coalition with Dr. Suresh. The next panelist is Professor Woojin Lin. Professor Wu is an obstetrics and gynecology professor from the University of Malaya in Malaysia. And among her many professional membership, she is a member of the WHO Screening and Treatment Working Group and has research interests in cervical cancer prevention and treatment. She plays an integral part in introducing program ROSE, and hopefully we'll hear more about this in Malaysia, which is a cervical cancer screening using self-sampling and the mobile technology. Dr. Sisi Seken Badmung is actually a director of medicine and medical device regulatory agency in Mongolia. She was the principal investigator for the studies on evaluation of the HPV vaccination impact that she helped to introduce in Mongolia as well. And the last but not least is Professor Fiona Russell. Professor Fiona Russell is actually here on apart from Professor Dr. James Fong, who is not able to be here. Now, Professor Fiona Russell is actually a pediatrician and also well-known infectious disease epidemiologist at the University of Melbourne, and her research has focused mainly on the Asia Pacific, especially in low-income country. She is a member of the HPV Vaccine Task Force Committee for Fiji and various countries in the Asia Pacific as well. And welcome to all the panelists again to this webinar today. So without further ado, what I will do is that I'm going to pose some questions to the panelists. And the first question I would like to direct is to Professor Suzanne Garland. Now, Professor, the world, as you know, is continuing to fight the COVID pandemic, but the WHO has chosen in the middle of the pandemic to actually announce the cancer elimination strategy towards 2030. Why now? Why not wait until the pandemic is actually a little bit less of a problem for the world? And why do we have to introduce it now? And in your opinion, do you think that the elimination strategy is a little bit ambitious because we have 9 years towards 2030? And is it really realistic for the Asia Pacific? To you, Professor Suzanne Garland.
Well, thank you very much, Dr. Ida. Indeed, I agree with you. This is really an historic moment that the WHO final day of the Assembly and formally announced the elimination of cervix cancer as a public health issue. And as you say, why do this when we're in the middle of a pandemic? Well, I think really we've got to grasp the nettles. We can never wait for the ideal time. We have to do it now. And that's because of these basic facts. Cervix cancer is largely a preventable disease. We know what the cause is, and hey, we have the tools to prevent it. Really, the global strategy that WHO articulates what must be done. And as has been mentioned before, these are 3 pillars of control: primary prevention, vaccination, which we'll hear more about; secondary prevention, screening and treatment of those precancerous lesions; and then, of course, those already infected and diagnosed with disease, with the cancer, treatment. And really, by 2030, we have to get on with this to achieve 90, 70, 90 in terms of vaccination, screening and treatment. It is a big ask. We really need to integrate what we're doing here. We can't just tackle vaccination on its own or screening on its own or treatment. If you look at the modelling, if you look at the economic argument, it's a strong one for adopting this strategy. It's within our reach. We need the political will of every country, and we need investment to do so. And really, awareness, education, advocacy by groups such as ourselves need to inform the service delivery providers. And really, if we don't do it now, it's been already predicted that we'll have a doubling of deaths from cervix cancer by 2040. Now, that's not very far away. And I think Suresh just underscored too that, in a sense, the pandemic gives us an opportunity. We need to take the positives. There's a lot of disaster and devastating news about the pandemic, but the general public has really been educated about the infectious diseases, about screening, vaccination and public health, and we really need to grasp that. And when you ask, should we be doing this in the APAC region? Is this too ambitious? Well, hey, if you look at the world data, the Globocan, almost 60%, 58% of cervical cancer cases occur in our APAC region, and 1/3 China and India alone. And if you look at incidence, you can see in purple the contribution from Asia and the same mortality and the 5-year prevalence. So we really do need to get on with this job and raise greater awareness. We need to strengthen the health systems for access to vaccine, screening and treatment. And we need a lot of people working together towards the ultimate aim of elimination as a public health matter. And that will take awareness and advocacy and partnerships. It will take surveillance, monitoring, evaluation. We need to utilise some of the things such as mobile technology. And really, if you ask me how are we going to do it in the APAC region, I look at what is the ideal test. We need something that is high sensitivity to pick up underlying lesions. We need it to be objective. We need excellent QA/QC programs, and you can read the rest here. We need good tests, and I think really what WHO is saying is we need high precision assays such as HPV-based screening. These have been around for quite a long time now. RCTs and pooled analyses show they're more objective and more sensitive than the traditional assays such as cytology. But a word of warning, when countries look at HPV-based screening, despite the hundreds of assays on the market you must use those that are pre-qualified by WHO, which is only a very few, and they must be validated clinically to pick up lesions. So we have a job to do there. And it really challenges in APAC is that we can actually piggyback on some of the things that have happened with COVID, whether it be at the patient level, the laboratory level, or consumable supply. And a lot of the machines that have been purchased and used for the SARS-CoV-2 can be used for HPV screening ultimately. We need women to be aware that there are good screening programs around. As been mentioned before, self-sampling is certainly a really big opportunity that would change the way we do screening. And I will just refer to the fact that the ROSE program has shown that this can actually be done. So I'll finish there. Thank you, and I hope that addresses your questions.
Thank you, Professor. Great. And Jeannie, do you have a question from the audience?
Yeah, we've got quite a few, but one of them, you were talking about validated technologies for screening, Suzanne, and we do have a question that's come in from Serge Bigabwa, and he's actually asked about the status of population-based screening using mRNA, E6 and E7 technologies. I think we're all now experts in mRNA since the COVID vaccines have come on the scene, but where are we at with those kind of newer technologies, Suzanne?
Yes, well, I mean, basically those tests that have been validated thus far are basically nucleic acid tests, DNA detection. Yes, there are some mRNA tests looking basically at the viral transcription. So in other words, picking up not just dead DNA, but a virus that's actually replicating. Many of those have not been as sensitive for screening, and I think there's really more work to be done. I didn't get time to mention it, but ultimately we may have a nucleic acid test with other markers that define women more at risk of disease. So, but that will come. And for example, partial genotyping has been adopted in some countries, but really maybe that we need to modify the algorithms of care that have been adopted thus far as we learn more as the molecular tests are used.
Great.
Thank you.
Keep the questions coming, guys.
Yeah, okay. And I think we should moving on, and I would like to pose the next question to Prof. Woojin Lin, actually. Prof. Wu, hello from Singapore, neighbor. Now, the WHO elimination strategy also quoted the second, the pillar of a goal of 70% of women to be screened at least twice in their lifetime. And but to know that a lot of us in the Asia Pacific region, our screening programs are opportunistic. And we know that if we are going to actually aim for at least 70%, is organized cervical cancer screening is actually the ideal, which is not what is practiced in most Asia Pacific country, because the best that we can quote is actually, as you know, is about 50%. So how do we get screening or HPV testing to everyone to get to 70%? And even if we get to everyone, how do we make women actually take it up? I mean, you can actually have the best screening program or screening tool, but if the woman's not going to take it up, then you know it's also not really going to work. So just to pose a question to you, Prof. Wu.
Thank you very much, Ida, and thank you everyone for this opportunity. I think there are many pillars into how we can get HPV testing out to our women. First of all, we can observe and learn what's happening in the COVID world to see what we have to, how we get ourselves ready for HPV test. As Suzanne says, we have the tools, but whether these tools can reach everybody, the issue of equity, the issue of the tools being there, but the women not wanting to have it, the financing, whether the healthcare professionals are ready to shift from cytology to HPV testing, that's also a very big element of it. I can tell you that I'm sure from some of our experience with the COVID vaccine, even healthcare professionals are casting doubt onto the effectiveness and the importance of vaccines. And these are the lessons we need to learn. HPV testing has been shown to work for a long, long time. It's sensitive, and we need to understand how we can employ the method to be used as a primary screening tool. Now, when we talk about clinical validity, many clinicians may not know what that means, because HPV testing started in the days of research, where we looked up to 50 different types or even 80 different types of HPV in presence in clinical research specimens. But really what we want to do now is to look for the HPV that matters, the 14 high-risk types. No more looking for the presence of low-risk HPV. High-risk types that matter. And this is where I feel sometimes our clinicians may not be so up to date yet. And I don't blame ourselves, because the numbers of tests that are coming up now are popping up so quickly, and we don't have time to learn about the clinical sensitivity. So first thing in HPV testing is to ensure that we are responsible to use the right test that has been approved by WHO, that has clinical validity for the population use. Now, the second thing we want to share is the adoption of self-sampling. I think someone said the other day that everywhere I go, I have a swab with me. So those who are not so familiar with self-sampling, women can now be empowered to do their own self-sampling with a swab as tiny as this. It's soft. You don't need speculums, you don't need beds, you didn't need a healthcare professional if you feel embarrassed. Women can now have their own cervical screening done twice or even once in their lifetime. So this is empowering. It means that we can shift screening from very busy and stretched services in the hospital to the community. And in a pandemic situation, we also can do this in areas that are open, that's not crowded, depending on each country's different situation. Now, the third thing then to talk about screening is being accountable for every screen that we make. HPV test is very expensive, and there's a lot of discussion about financing and budget. And therefore, we need to be responsible to ensure that it is shared equally among all the women. Meaning, one woman doesn't do a test every year for 5 years, whereas every woman needs at least twice or 2 tests in their lifetime. And what this means is that we need the infrastructure, or what we call a screening registry, to ensure that this can be done. And it can be, because with the vaccines, we now see that governments and NGOs are pushing out tools to ensure that we capture every single person, and we ensure that we can monitor that they get their 1 or 2 doses, right? So these are the technology we can use and we can learn to ensure that when the pandemic settles, we can roll out our screening and our treatment strategies very quickly.
Thank you for that, Prof. Wu. Jeannie, do you have any questions for Prof. Wu?
Yeah, I think there was a really interesting question that came in actually from Esther Konoven, and she was asking about HPV screening for boys. You've already really said, Professor Wu, a lot about barriers and the ways we can overcome them for girls and for women. But what about for boys? Is there a role for mass screening of HPV in our boys?
Not at all. There is no effective screening for head and neck cancers or any other cancers in male or female except cervical screening. We're not at that stage where there needs to be screening. There's another thing I want to touch on. When I see patients with cervical issues, they often ask, "Oh, I've got HPV. Do I then need to treat my partner or contact trace my partner?" And this is where we need to make a stand that HPV is not a sexually transmitted disease. There doesn't need to be contact tracing. There's no antibiotics, and so besides learning about HPV tests, we also need to deal with the stigma. And healthcare physicians and healthcare professionals really have to ask themselves, do they bring in the prejudices or the stigma onto the population in which they screen? So we've got lots of work to do. So
Would vaccinating
no screening of boys and no contact tracing required. Suzanne, would you agree as a microbiologist?
You're mute, Suzanne.
Better unmute myself. Totally agree. As a sexual health physician as well, I think we have to teach people this is not your traditional STI. It's so common. Most people get it at some stage. Most people get rid of it with a healthy immune system. And it's, you know, to be destigmatized. I totally agree with you.
Yeah. I think with that, we could actually now move on to our first line defense question, which is HPV vaccination. And I would like to pose this question first to Professor Fiona. And then 90% of girls to be vaccinated by 15 years old by the year 2030. And obviously, we know that the school HPV vaccination is an ideal way to provide access for HPV vaccine for these girls. Now, you yourself plays an advisory role in HPV vaccination in Fiji and other various countries in the Asia Pacific. In your opinion, what are the various challenges in introducing HPV vaccination in the Asia Pacific countries, Professor Fiona?
Thank you very much, Dr. Ida, and thank you very much for the organisers for the invitation to be part of your very fantastic panel this afternoon. So, yes, I think having sort of worked in the Asia Pacific for the last 2 decades, there is quite a degree of inequity, I guess, in terms of access to vaccines, and particularly new vaccines. As Dr. Ida said, I'm a paediatrician, so a lot of the work that I do is in the infant programs, but with all new vaccines, including COVID, and HPV is one of those. And so what I've seen in particular is that this vaccine is often available in the private market, but it's not available in the public program, in national programs, and so it creates enormous inequity. And additionally, particularly for low-income countries and low and middle-income countries, and even middle-income countries, there's certainly the WHO data from the to show the model data or the estimated disease burden data, but often that's not enough for countries, because often countries know they don't actually have so much data, and I'm talking now more in terms of the low and low middle income countries. And so this is makes it very difficult when there's no actual data for decision making. And so, there's a number of ways, and so in the number of countries that I've been involved with trying to, and working with governments is essentially what I do, is to take it from a different angle. So some countries have got data that's able to be analysed, so you get the epidemiology of disease, and so you can make a case based on the disease burden. Other countries do not, and some countries have got stored samples, cervical cancer, stored samples which can be then genotyped, for example, and you can pull them out of storage and get them tested to make a case. And then in Ethiopia, actually, there was really no data at all, or very little bits and pieces. So, but really what was powerful there a number of years ago was to do qualitative research and actually interview communities and families and talk about the social impact, and which was really incredibly overwhelming. And hearing those stories was what initiated the HPV pilot program, and then the national program to be introduced. So, and then in other countries in the Pacific I've been involved in, again, tiny countries, no disease burden data, but what we did there was looked at cost effectiveness analyses. So it depends on, what's available and what's important for decision making. So there's a number of different options, but certainly partnering with government and decision makers from the beginning is really critical, rather than, I'm an academic and researcher as well, but all my research is with government and the decision makers from the very beginning, and that's really critical, because they're the ones that then translate, are involved and immersed in the data and the findings to be able to then take it to the next step. The other thing, so when countries have made the decision to introduce, then there's a number of additional barriers, I guess, and the startup cost to introduction is actually the most expensive bit. And so again, low-income countries and low and middle-income countries often need assistance for those startup costs. So, there's the community mobilisation, the health literacy needed, and the development of those tools to get the everybody on board and get the community mobilised so they want and demand the vaccine, and to prevent vaccine hesitancy. There's the increase in the cold chain capacity, the reporting systems, things like that. And then, of course, there's the logistics of actually reaching girls twice in a school-based program, but, very importantly, trying to find those out-of-school girls as well. So I think, the other really critical thing is, and I think Suzanne has alluded to this already, is about the advocacy with the professional societies such as this. But I'm a paediatrician, and as I say, I do new vaccine work. And so in the countries that I've been involved with, it's the paediatricians, and each country is different, of course, but it's the paediatricians that sit on the National Immunisation Technical Advisory Group, because by and large, most new vaccines are in the infant program. And even with COVID, even in Australia, it's paediatricians in this country that are actually, running the COVID vaccine program by and large, because they're the vaccinologists. So, but of course, obviously all the gynecologists, the cancer specialists, the sexual health, everybody is really needed to bring together, and the more that can be brought together as an advocacy is really critical. And then, just to finish, just on the global level, then of course we need an increase in financial investment and improved supply, and then obviously increasing that visibility of this issue and making it a very a very visible issue, so people want to invest in it and prevent it, and to achieve we'll try and achieve these targets at least by 2030.
Yeah. Thank you, Professor. Yes, as you can see, understand now as a vaccinologist, and then there's quite a few barriers that actually we have to consider as well in the Asia Pacific. Now, Dr. Segi, you're actually involved in the implementation of the HPV vaccination program in Mongolia, and I was wondering, after all, what Professor Fiona Russell has been saying, what is your experience in terms of introducing the HPV vaccination in Mongolia, actually, and how do you overcome the challenges that you faced during this time?
So thank you very much, Ida and organizers, for this great opportunity to share experience of Mongolia. So Mongolia has the highest rate of cervical cancer in the region, and we had very different story of comparing to many other countries, because we introduced the HPV pilot vaccination program in 2012, but it was interrupted because of the unsubstantiated negative claims about the HPV vaccine, and it resulted that 1/3 of the target girls missing out, and the vaccination coverage for the was 65% of the target 11 to 17 years old population group with complete 3 doses. But the coverage for the first dose was 77%, and for the second dose was 75%. But the main thing was the vaccination campaign did not reach full target coverage due to community resistance and vaccine hesitancy and misinformation about infertility among girls. And it was really quite shocking experience for our country, with very good established childhood immunization program with more than 98% of coverage for the childhood vaccine. And because of all this misinformation and vaccine hesitancy, the HPV vaccination program stopped in our country. And what we've learned from our introduction of HPV vaccination is that the ineffective communication and not proper awareness raising was the key for the failure for HPV vaccine introduction. And it showed that we need to prepare well for the new vaccine introduction and prepare for the risk communication. And it took for Mongolia almost 8 years to bring the vaccination back, and with strong advocacy from healthcare professionals and researchers, civil society, targeted stakeholder action, and as well as quality local data on effectiveness of HPV vaccine, and formative study to identify information and communication needs among key population groups. And after all this advocacy work and communication, the government had decided to introduce HPV vaccination at national level from 2020. And government made the decision to introduce and made costing of the National Strategic Plan on Prevention of Cervical Cancer for the 4 years, and made proper planning to target the coverage rate by 74% and immunize girls age 11, and made a cost estimation how much funding we need for the next 4 years. So we have really different story from.
Yeah, I mean, yes, those are one of the main challenges. Jeannie, do you have any questions for either Professor Fiona or Dr. Sege?
Yeah, I think some of these questions are just amazing. Thanks so much for everybody who's putting these great questions in. I was really interested for Fiona. We had 2 questions from Kritika Pudel and from Anjali Rao around barriers to vaccinations coming in from the parents, where perhaps the parents are not brought on board. And I imagine that, Segi, that's a very similar experience for you guys in Mongolia. What do we know about improving outcomes by engaging the parents? And Anjali also asked about sex education in the context of HPV vaccination. Does that help? Would that help for improving uptake? Perhaps I can direct that to Fiona first.
Thanks, Ginny. Yeah, I think it's absolutely critical. I mean, of course, it's absolutely critical to engage the parents, and as part of the community mobilisation is the parents, but also, you know, the girls as well. In Fiji, when they introduced the vaccine, the consent forms were sent home in the girl's school bag, and if the girl didn't know anything about it, they're not going to pull the consent form out of their bag, you know, to give to the parents. So it's absolutely critical to have a broad, you know, and through the school and through the teachers, actually teachers through a school bag program, the teachers are absolutely critical. And so, you know, having both, you know, the nurses, you know, what we find in vaccine programs, the people that, you know, the trust is mostly with the health professionals, so it will be the nurses who are coming to the school to give the immunisation. But in this particular situation too, it's the teachers and having the principal. The principal is absolutely key. If the principal is not on board, you know, that's a really, you know, you're not going to get those girls in that school vaccinated, or you're not going to get the parents on board, because the schools can really work with the program. And so in doing all of that, I think, yeah, the very careful community engagement and with the family is absolutely critical. And sorry, Jenny, what was the second question?
It was around sex education being kind of co-timed with the delivery of the vaccine. Does that help improve uptake?
I think, you know, each context is a bit different. I mean, in the sense of how the perception of that. I mean, certainly with the rollout of HPV and the target group being pre-teens, it's, you know, we recommend that other adolescent programs or health activities are added on at the same time. but some communities, have different religious or very strong religious beliefs, and so coupling sex education with the vaccine may not be the best thing to do in that particular environment, but instead really emphasising the cancer prevention side of things rather than, not to say that sex education shouldn't be done, but coupling it together is probably not, in most contexts, probably should be separated. Yeah.
Can I just direct a question to Tsegi as well? We've had a question from Ajay Tomar around cost being a real barrier to implementation of the vaccine on a broad basis. Are there any scope for movement there in terms of vaccine cost?
Thank you very much, Jenny. So I think many low and middle income countries face the similar challenges related with financing and budget allocation for their vaccines. For example, for Mongolia, the government had made a calculation that we need to have around $4 million to vaccinate eligible group of population. And this is definitely the challenging part facing for many countries going out from the Gavi, not eligible for the Gavi funding, and having getting vaccines with the lower cost. So this was the main issue. And also I wanted to add to the previous question about the parents and teachers' perception. And when we've done a study around the identifying the needs of the parents and teachers about information on HPV, we found the same results, that a parent's decision and consent form was really important. And another cultural thing, for example, for our country was that many children who are living in remote areas, they are far from their parents. And one thing which we had to consider is, because parents live far from the school dormitories, in most of the cases, teachers had to sign the consent form instead of parents. And in that case, providing proper education and training and information to parents, to teachers, was really critical thing, for example, for our country experience.
Thank you, Dr. Tsegi. I think we have to move on. There's just so many questions, Ginny, isn't it? There's amazing questions coming in. But I think we might have to move on. And the next question that I would like to pose is to Dr. Suresh, basically, first. And this is about the third pillar of the WHO elimination strategy. And as you know, it says that the goal is to have 90% of women identified with cervical disease to be effectively treated. And certainly Malaysia is one of the countries that's exemplary with the ROSE program and also your school HPV vaccination as well. So Dr. Suresh, what do you think are the challenges that we will face in the treatment of cervical cancer during the COVID-19 pandemic? Because I understand you have co-authored a paper published in the Journal of Obstetrics and Gynecology Research on this subject. And what do you think is your recommendation in dealing with the treatment of cervical cancer disease, even during the pandemic this time?
Thank you very much, Ida, for your question. Now, treating cervical cancer during the pandemic really is a challenge now. And there have been a number of advisories that have gone out to assist clinicians. Basically, if you are in a situation where you have a lot of active COVID infection, then the gynecologist should consider options that would reduce the number of surgical interventions that may be associated with prolonged operation time, transfusion risk, infection to medical personnel, and ICU admissions. The other thing to bear in mind is that there is a risk when you operate on patients who have active COVID-19 infection, whether they pick it up immediately after the operation or if they are tested negative at the operation because they are in the incubation phase. Some of the early studies that came from Wuhan showed that the ICU utilization rate was about 45% and the mortality rate was 20 to 25%. In general, if you are faced with that active COVID-19 situation, it's generally believed that about 3 to 8 weeks delay in surgical treatment it can be accepted, but you need to reevaluate the situation every 2 to 4 weeks, and we prioritize patients who are highly curable, who have advanced disease, and have symptoms that require palliation. Specifically for cervical cancer, if you have got early stage cervical cancer, you can delay treatment for up to about 4 weeks. And if you've got very early cancer, microinvasive cancer, which has been completely excised at loop dichotomy, you can wait till about 10 to 12 weeks after surgery. With pre-invasive disease that is low grade, you can postpone evaluation for 6 to 12 months. And with high-grade lesions, you can postpone evaluation for 6 to 8 weeks. We also need to rethink how we treat patients. So if you have microinvasive disease or low-risk disease where the tumors are small, less than 2 centimeters, with no high-risk pathology, then you can do a simple conization or simple trachelectomy. And when you have big tumors and you can't operate on them immediately, you can give them neoadjuvant chemotherapy. So these are some of the measures that clinicals can use during active COVID-19 infection.
Thank you, Prof. Suresh. And then I would like to direct the next question actually to Prof. Woo. Prof. Woo, so in terms of effective treatment as well for pre-invasive cervical disease, as you know, we do need training. 90% of women to be treated, effectively treated in the Asia Pacific towards 2030. How are we going to actually manage to train the doctors to that level, you know, to treat, to get a 90% treatment, effective treatment, basically, not just treatment, but effective treatment?
So Ida, the first thing I want to touch on is Asia Pacific is quite big. You and I are probably used to the idea of doctors doing the treatment, but in many areas now with availability of thermocoagulation, I think we need to think out of the box. For those countries that have lots of experiences on performing VIA, visual inspection, with acetic acid or with Lugol's iodine, I think that workforce can be used to use thermocoagulation to treat those who are HPV positive. And if they have any doubt that there's cancer, then they can then have a second line of treatment in the hospital. I think someone mentioned it. So should we be pushing screening to the primary care? I would say yes, very much so. Cervical screening should be done in primary care and should even be done in the community. And I think with the availability of now mobile inspection and some AI tools coming in and cheap thermocoagulation, we really need to consider empowering our community healthcare workers. In some countries, it may not be the case in Singapore, Malaysia, and our primary care physicians to perform simple treatment so that the more complicated cases can then be dealt with in the hospital.
True, that's true as well. Because thermocoagulation, as you know, is a very simple treatment that can be learned very quickly, and it's not expensive as well. Jeannie, back to you, honey. So if there's any questions out there?
So many, and they're just coming in from all over the world, which is just so exciting to just get such a diverse group of people in on a single webinar. Kind of thanks COVID for that. It's been an amazing experience. There was one question that I thought was fantastic from around vaccinating very young children. Like, could HPV vaccination be included in a childhood immunisation program where parents are very open to their children becoming vaccinated, and perhaps we'd increase uptake then? Do we have any takers to answer that kind of question?
Professor Fiona? Yeah.
I can answer that. Yes, absolutely. I think it's a fantastic way forward. We've done that already with the hepatitis B vaccine. So hepatitis B is given to babies at birth, and the reason why we give it is to prevent infection with hepatitis B and to prevent adult liver cancer. And so, and that's been a very effective way. And hepatitis B is sexually transmitted and bloodborne and all those other things as well. So it completely gets around anything to do with sex, and which is really important, particularly for this vaccine. It's a vaccine to prevent cancer, because a lot of the barriers is if people think it's a vaccine to prevent a sexually transmitted infection, that's where people and that vaccine hesitancy and all of those things manifest. But there's a clinical trial in the Gambia in Africa, randomising 4 to 8-year-old children and looking at that. But, you know, one of the critical things is how long does the protection last? Because we know, you know, obviously, well, unless children are sexually abused, of course, most people get, infected with their first sexual debut, which varies in different countries as to what age that is, but it then has to last, that protection has to last throughout the time that that person is sexually active, and particularly, you know, if they have other partners as well, so in changing partners. So that's the key thing, is the long-term protection on that.
Fantastic. Thanks, Fiona. Sorry, Suzanne.
Could I just add that there is data on 6-year-old children, and they do produce really good neutralising antibodies. So I certainly support exactly what Fiona just said.
That's really fantastic information. Thanks for that. I think the most common questions that we've had in the chat box for those who've not been able to get in there is just looking for some clarification around sexual transmission and HPV. I think it's been really well explained by Professor Wu and Suzanne in the chat box, but just for the benefit of those who've not been running their chat box by the side of their panel discussion, I know I'm not a good multitasker. Suzanne and Professor Wu, can I just get you to explain what you've done so eloquently in the chat box, just to explain that link there?
So I think one of the most common scenarios when women are faced with an HPV positive test, the first questions they will ask, and this occurred with HPV vaccination as well, is who did I get this from? And is this a sexually transmitted disease? And with the benefit of what we have learned from HPV vaccine programs and how we counsel, we now know, and we have data, that HPV infection is extremely common. 80 to 90% of men and women will be infected at some point in their lives. And so we don't classify it as a sexually transmitted disease, because disease by implication means that you are unwell with it. And this is where you say there's no excessive vaginal discharge, there's no excessive bleeding. It's asymptomatic. And what you're really concerned about is whether it's associated with cancer. So there's no treatment required for the partner. And really we have to work very hard at destigmatizing. And someone in Nigeria said it's even harder in those countries. And, you know, we must remember that in certain communities, there's still stigma with having monthly menstruation. And these are the countries and areas we need local champions to deal with the issue of stigma. And someone like me or Ida won't be able to deal with that in those communities.
Yeah, thanks. Suzanne, anything to add to that, just for clarification?
I think I'd agree totally with what Woojin Lin has said. I mean, it's an infection. The only time you get a manifestation is if you have genital warts, which are caused by the 611, the low risk types. But no, it's not a disease per se, like gonorrhea, that gives you a discharge. And I think people forget that. And it is really, really common, and it is associated with numbers of partners. That doesn't mean the person who is HPV positive has a lot of partners, but perhaps their partner has had a lot of partners, so they bring the risk factor to them. So I think, you know, why do we say destigmatize? Well, you could just have genital skin contact with another person. It doesn't have to be intercourse per se. And that can pass on HPV. So it's common, and most people get rid of it. And really what's important is if it becomes a chronic infection. And some of the determinants of chronic infection we know are smoking, another good reason not to smoke, or immunodeficiency. And then there's probably other factors that we don't know.
There was just another question that I thought was very pertinent to now from Vandana Gupta around co-administration of HPV and COVID vaccines. Suresh, do we have any data around that at the moment? Here in Australia, we are not even co-administering our COVID vaccines within 2 weeks of any other vaccine at all. But what do you say, Suresh, what's happening where you are and what would you advise?
I don't think there's any data with co-administrating these two vaccines, but these are things to think about. With the COVID-19 situation, we can learn a lot of lessons that has been alluded. One is how to vaccinate effectively. The other is how to contact trace. So in the context of, say, doing HPV testing, you can, all the lessons that we learned, how to trace people, how to get them isolated and quarantined, can be used in the future for following patients up who have got, say, a positive HPV high-risk test, so that they get the proper evaluation and they get the appropriate treatment.
And Ida, the last thing that really struck me from the Q&A section was just the enormous support for self-sampling from so many people who are attending from all over the world. It's really, I do acknowledge that self-sampling does have some cultural issues in some parts of the world, but I guess, Professor Wu, this is an area that you've really championed around taking meeting people where they're at rather than trying to control the agenda from on high in the medical profession. Anything to add there around self-sampling?
I think there were some issues of wondering whether self-sampling is different from a lavage. I think that's quite different. Conventional lavage, in the past, you want to get cells as well. So the idea is that vaginal lavage will be able to get DNA for HPV testing and also cells for cytology. Now, a self-sampling tool like this is actually a low vaginal swab. It doesn't need to go into the cervical region. So women don't need to put it all the way up. There is a red line here. And this is a very simple and cheap tool to perform self-sampling. And that's what people need to understand. It's simple. Now, in terms of the studies that are done on social cultural barriers, most of the women who come forward for self-sampling would not have otherwise come forward to a healthcare professional for a pelvic examination. Now, the other thing that you need to know is that if you take a swab using a flock swab like this swab can actually stay in room temperature for up to 2 weeks before it's tested. So it means that you can bring it into the interior or rural areas and bring it back to a central facility for testing. And it is as effective as a clinician-acquired sample. And these have all been proven in studies, and you don't need any more research to get that done. And in terms of validity of the self-sampling, enough studies have been shown that it is quite good in getting sufficient DNA for HPV testing.
Thank you, Prof. Wu. And I think we are actually, there's so many questions, Ginny, but I thought that, just pose the last question here, and was wondering to see who can, is there any takers for the last question? So do we think that the Asia Pacific should push for a screening and vaccination registry? And if we are going to push that for the Asia Pacific regions, the low and low middle income country, how are we going to do that? Any takers? Silence.
We have to start with a call to action.
Exactly. So that's what we're going to be doing next. I mean, I think the webinar has been absolutely great response from everybody. Thank you to the panelists and Ginny and everybody that is here. And I think since we are coming to the end, I would like to actually then propose a call to action actually. And then I think for everybody here, I mean, we do the first call of action to that I would like to propose is that We know that cervical cancer is the biggest killer of women worldwide, and about 60%, and Professor Suzanne Garland is saying, is actually in the Oceania, Asia Pacific country. Now, despite this, the global recognition and representation from the Asia Pacific region in cervical cancer prevention and HPV vaccination issues is actually very limited. Okay, so there must be more global support. There must be more recognition and representation from us in the Asia Pacific community in terms of the struggle that we are facing to how to overcome challenges towards the cervical cancer elimination in our region. And the global spotlight actually must also shine on us. So I think that's the first call to action, is that for us to have better recognition and to get more support globally in terms of cervical cancer screening and prevention. Now, the second call of action that I would like to make is that there are various global organizations, societies in varying fields, and we already know that Professor Fiona is a pediatrician, Professor Suzanne Garland is a microbiologist, we have clinicians, we have public health specialists like Dr. Segi, academicians, research, virologists, vaccinologists, and all of us are working towards one cancer, working towards one virus, and actually towards one goal, which is global elimination of cervical cancer. And I think with all that is happening with COVID and the realization of what cervical cancer incidents can happen if we ignore this, actually it is time now, and to borrow the saying from my colleague, Professor Philip Castle, that the world needs to stop working in silos. We all have to start collaborating with each other. We have to start sharing ideas. We have to start sharing experience and expertise towards this one goal that all of us have dedicated our life to. So I think that, you know, in terms of cervical cancer, everybody's working in different fields to try and help in elimination, but we now have to kind of like start working together towards this goal. And with that, if there's any other comments from the panelists, Professor Garland, do you have any other comments?
I guess I'd just like to endorse, I also carry my swab around because the self-collected sampling in sexual health, we've been working on that for more than 20 years with the power of PCR, the polymerase chain reaction for detecting various STIs. And it really started off with as a T-test or the tampon test, because most women will have used tampons. I know not all cultures do, but that's how we started off, looking in remote regions of Australia. How do we define what the prevalence of STIs were, chlamydia, gonorrhea, etc. So I'm all with, Yin Ling on this. But again, just to sort of endorse the concept, it's not, it's something that has been used and has been used well. And patients like to have the control themselves. The same in obstetrics, we use it for group B strep carriage.
Yeah. Dr. Suresh, do you have anything else to add?
All I think is, as has been discussed earlier, we should not be discouraged by COVID-19. We should look at COVID-19, try to learn lessons from COVID-19, and as soon as we get over this pandemic, I'm sure it will happen in a year or two, we should just move ahead with all our efforts to help eliminate cervical cancer.
And Dr. Segi, do you have to add anything as well?
I just wanted to add that with this global vaccine shortage and COVID pandemic, we should focus more on availability of HPV vaccines for girls, especially for many low and middle income countries, and also consider the possibility of single dose vaccination, because there is a long way to go, and that's why maybe we should consider these things as well. Thank you.
Thank you very much. Professor Fiona, do you have anything to add as well?
Yes, look, I'd just like to add that I think we should see the COVID situation not as a barrier, but potentially an opportunity. Otherwise, you know, nothing will happen with anything. And I think where there's a will, there's a way. And we've seen that with COVID vaccine, you know, and the difference between COVID vaccine and my cynical way is that, you know, we saw a disease that infects older men, and particularly older men in Italy and Spain and in Europe. And so, you know, and so that really, you know, in rich countries. So anything is possible. So I think, you know, we obviously need to raise the profile. You know, there's more manufacturers. There's so much more interest in vaccines now, you know, from the vaccine side of things anyway. There's new technology. I don't know about the application of mRNA vaccine, but, you know, this is technology, I mean, but this is, you know, exciting that with all the input into COVID vaccine development, I think hopefully there'll be newer manufacturers with HPV vaccine as well. But I think really, I think take the opportunity, because I've been working in new vaccines for 2 decades, and this has been the most rapid rollout of any vaccine obviously ever. And so, you know, it can be done.
Prof. Wu, do you have any last words as well?
I think each of us will have to work out how to get vaccines into the arms of girls and how to get women screened, and the solution will be different from different communities. You need to ask yourself how you can make yourself that vessel or vehicle to be that change for your community first, and the policies will follow thereafter.
Jeannie, do you have any last words as well?
No, just thank you for joining. This was a really big deal for us at the Asia Pacific HPV Coalition. This was our, I guess, our coming out parade, and the support of IPVS has just been amazing. And and to everybody who joined us for your support of us in the Asia Pacific, who are trying to collaborate not only with each other but with everybody here. So thank you.
Yeah. So last but not least, just to remind everybody as well, I'm just going to share the slide again. Hold on. Okay, can you see the slide? So basically the IPVC, just to make an announcement that there is going to be an IPVS conference in November 15th to the 19th, and virtual conference. And please join us, I mean, you know, for the conference. And there's a lot of exciting topics that will be discussed in the conference as well. And the last but not least is that thank you again to everybody for your presence today, and for the questions that we're not able to answer due to time. I may be able maybe to persuade the IPVS to actually put them in our new HPV, IPVS HPV hub. We'll see, okay? Watch this space. And then there are a lot of really great questions, and thank you everybody for the support. And if you don't mind, on behalf of the IPVS and the Asia Pacific HPV Coalition, would be grateful if you could actually just do complete a post-webinar survey and to claim your certificate for the participation. And any kind of feedback, good and bad, is actually really appreciated, so that we can improve how we make future events for all of you in future as well. So thank you so much to all the panelists that have spent their time with us today. Thank you, Jeannie, and also thank you everybody, and have a good day.